Performing complex surgical procedures without using real-time imaging is like driving without your headlights on. Risky. Static images taken with an MRI before surgery begins can't provide a real-time view. During surgery, things change. Organs shift. Movements occur that can't be predicted. BK Medical's active imaging with intraoperative ultrasound turns on the lights and helps surgeons visualize where they're going in real time. When it comes to life-saving surgery, details matter. Today's active imaging technology gives surgeons much more confidence and the potential to enhance levels of surgical accuracy. Now they can locate and remove tumors or even small pieces of tumor they may have previously missed using only pre-op imaging. BK's active imaging technology can dramatically increase the chance for total surgical success. BK Medical's active imaging technology turns on the lights.
To do it, and ultrasound is one of them. So it sounds like your NeuroSound Academy is driving things in that direction. So we've done quite a bit of work, and I'll show some of the things we've done which tie into what you've said now. And I think one needs to always start with acknowledgements. So this is some of the hospitals I've worked in: the Red Cross in Cape Town, Redcliffe in Oxford, and then currently the Steve Biko Academic Hospital in Pretoria. Those are my disclosures. So as part of this work, and I think it's quite nice to know that you're applying your mind to something and they grow into bigger things. So this is part of a spin-off company that's come from some of the ideas we've had, and I'm a medical advisor for that. Some of the workshops we run, just as a start off, the Whoopin workshop in Tübingen, Germany, is something myself and a fellow pediatric neurosurgeon colleague of mine, Martin Schumann, run together in Tübingen. We're going on to our 6th year of that now. Brain ultrasound organization is something I'm involved with, together with some of the leading thinkers in brain tumor surgery in the world, really. And then just a plug-in for the WFNS meeting in Cape Town, 4th to the 8th of December. We'll also be running, amongst many other workshops there, an intraoperative ultrasound workshop. So I'm going to go fairly quickly now because we've fallen a bit behind with time. So I'm going to skip through some of the slides, but this is what the talk overview is really. It's important to remember that the first description of use of ultrasound in medicine was actually, they thought they were describing a brain tumor. It turns out that it wasn't actually the case, but things have come very much full circle now. So the use of ultrasound in neurosurgery has really, come, as I mentioned, full circle. So it's important to also remember that ultrasound really is just, sound waves above the audible human frequency. Diagnostic ultrasound ranges between 2 and 18 megahertz initially, but some of the more refined probes go even above those. And the therapeutic ultrasound, which I'll touch on very briefly at the end, much lower frequency, but you can use these to treat and ablate tissue. So the basics of ultrasound, like I said, it's a sound medium propagated through tissue. These alternating bands of compressions can be converted into a wave. Things you need to be fairly familiar with are concepts like wavelength, frequency, velocity, not really part of the sort of spectrum of the talk, but just to complete the basics. Things have come a long way. These were the static scanners. You needed to immerse the patient into what was called a pan scanner. You needed water around the patient. It's quite a massive undertaking. If you look at where we've come to now, there's tremendous sophistication in the frequency of the probes, the size, the improvement down to these kind of portable units, handheld units, a wide spectrum of ultrasound probes that really allow us to access and image almost every cavity related to the cranium. The image display is really the most commonly used now is B mode, a brightness display. The advances on that, the Doppler effect, which allows us to use something called color Doppler, which is great for vascular lesions. Something I use for virtually every tumor now is something called power Doppler, where it gives you almost an angiographic or an ultrasound angiography of the tumor layout. It doesn't give you flow, but it does give you a sort of strength of flow within the vascularity or the vascular structure. Ultrasound safety is incredibly important to bear in mind, and this is a good resource for those of you interested to try and download. There's been no demonstrated deleterious effect for ultrasound, but just the absence of harm, of evidence of harm, doesn't mean there's no harm. So you've got to be aware at least of what these safety guidelines allow. Broadly, that's what they say. But the bio effects related to ultrasound really come down to these two things, the thermal and the non-thermal effect. So the thermal effect is really when ultrasound travels through tissue, the energy is converted into heat, and hypothermia is a known teratogen. So you've got to make sure that the length of exposure and the frequency is something you're familiar with. Non-thermal effects are things like cavitation and streaming, and I'll show how these have been used therapeutically in something called high-intensity focused ultrasound. The safety indices, largely you stick to the thermal and mechanical index, which is always displayed in the top, usually the right-hand corner of your screen. Thermal index of 1 means, the temperature rise in the body would be likely 1 degree. It must be below 1.5. And the mechanical index tries to predict the type of cavitation or non-thermal injury. So that must be within the safety gamuts. The program, the unit controls, I think those are things a lot of you will hopefully be familiar with. So that brings us to what is ultrasound used for in neurosurgery? And I would argue there's no more diverse, useful tool for the neurosurgeon than the ultrasound machine. In a diagnostic capacity, I've structured my talk really around this. So what we can diagnose, intraoperative navigation, if you look at the spectrum from hydrocephalus, shunts, endoscopy, Chiari-1 malformation, all the way to peripheral nerve surgery. Important also to remember that surgical tools like the CUSA, piezo surgery are all ultrasound based. Some of the advances are things I'll show just briefly in the end now. I will try and catch up for time, and then I'll touch on high intensity focused ultrasound. So the bedside diagnosis is really, in children, what's most important for us. And the anterior fontanelle that's patent really gives us this fantastic window into the brain. You can see what a coronal ultrasound looks like, and a sagittal you can image all the way down to the brain stem. Radiological assessment is our crux, CT scans, but they come with certain shortcomings. We end up scanning kids much more than we should have in any sort of pediatric hospital. We must bear in mind that the dose of radiation that the brain is exposed to is significant. With 1 CT head, the equivalent of 100 chest x-rays. And if you look at the compound risk, you're looking at exposing kids who are scanned more frequently to almost triple the risk of brain cancer over their lifetime. So for all of us, I think if you look at South Africa, you can go northwards to Europe, you can go, North America, South America, to Argentina and Brazil, where you guys are now. The one thing that's consistent is that children who present to us should have been always, I think, diagnosed earlier. And raised intracranial pressure is the commonest underlying feature of these diseases. So our goal initially was to try and aim, to identify, validate, and refine techniques. Invasive monitoring for ICP forms the crux of what we do, but we know the shortcomings. And that sort of underscores this need for a reliable, non-invasive techniques for the reasons I've listed there. So the available techniques range from clinical assessment all the way to complex electrophysiological techniques. The eye particularly allows this fantastic portal to try and access information, and there are several methods for doing that, but the ultrasound method that's most widely described is scanning of the optic nerve sheath diameter. What it involves is placing an ultrasound probe over the eye. You scan the eye, this is what it looks like. You use parameters to measure the optic nerve sheath diameter. And that's what it looks like. You can see there are several publications refining the technique, for supporting at least and enforcing the technique. So it definitely is incredibly useful. This is some of our own work where we published data with ICPs ranging from 5 to 20 and the optimal cutoff values for predicting that. We also showed that the diagnostic accuracy is good. It's not great. It needs some work. And this was also reinforced by work from Germany, completely independently done, basically verifying some of the data that we published. What we did do, though, as part of this project was we identified another dynamic technique, which we call the deformability index. And if you use that sort of pulsatile measurement of the elasticity of the sheath and you punch it into a regression formula, it's actually a pretty good predictor of ICP. You can look at ONSD, and then once we combine these two, you can see we've significantly improved that. So effectively, the technique involves 10-second videos collecting movement around the sheath. These are punched into an algorithm, and for those of you interested, we've published several articles on that. And it's quite good for picking up dichotomized ICP, so above and below 20 millimeters of mercury. This work was advanced on significantly. There's several publications now from Norway where we tried to standardize the technique using a machine learning algorithm. We've also incorporated papilledema, automated papilledema, and you can see a segmented sort of diagram. Again, machine algorithm or learning based, trying to improve the accuracy of the technique. So that's diagnostics. If you come into intraoperative ultrasound, there are several indications, like I've pointed out. I think the ergonomics of your theater and how you lay things out. So we've worked out a very good structure where we get our monitoring, electrophysiological monitoring, our ultrasound in the line of sight, our exo endoscope also behind that, and I've got several registrars obviously working with me. Where there's been an interest in using a handheld ultrasound probe intraoperatively. Something I think is useful, but in our hands, not really necessary at the moment. And then things like elastography, which I'll show later. So the modern neurosurgery theater is quite complicated, and I think the ergonomics and the layout, like I pointed out, is incredibly important. You need to have a theater that's not overly cluttered. We favor a kind of combined structural and functional monitoring, so combining electrophysiological monitoring with structural imaging in our case. The ultrasound, this is a case demonstrating that concept. So we use the suction, the mapping probe or the mapping suction to map out the motor cortex. This is a tumor right over the motor strip. So we map that out. We use the ultrasound to kind of define our tumor and our resection cavity, and you can see we get quite a nice resection, and all our electrophysiological parameters in this particular case were preserved. So this combination of ultrasound and intraoperative neurophysiological monitoring, I think, is incredibly attractive. The idea of the navigation technique, if you look at the benefits of ultrasound, they're pretty clear. In my practice, I use it for basically every intraoperative procedure that we can conceive of. The necessities are dual window, sterility, you need good image quality, proper display, the probe you use and the user experience are exceptionally important. And like I showed, all those causes that we showed initially are quite useful in teaching that skill. So for hydrocephalus, you can see these are quite small ventricles, and this is a video I always enjoy showing. Sagittal view showing the catheter coming in from the occiput. We think we've placed it correctly. Ultrasound allows you to just flip the probe, and then you're in a coronal plane, and you can see ideally the catheter should be there, but we're a few centimeters off. So you're able to correct that in real time anyway. We also we did a study correlating ultrasound and CT measurements. We used objective and subjective techniques. This was also published by other groups, and the German group suggested that ultrasound-guided ventricular catheter placement should become standard of care. The Healthcare Research Network, hydrocephalus Research Network, also suggested it, but not as strongly as this paper from Germany. So the adjuncts that you'd use, or at least where ultrasound can be used, if you look at navigation, for endoscopy assistance, for ultrasound, augmenting these things with an imaging technique like ultrasound really makes a big difference. In the context of neuroendoscopy for complex hydrocephalus, electromagnetic neuronavigation has been described as a useful adjunct. There are several papers that support that. This is what our if I can go back there. What our protocol involves. There have been some publications suggesting that if you combine real-time imaging, in this case intraoperative MRI with neuronavigation, you do get some benefit. Obviously, intraoperative MRI is limited to very few centers, even around the world. This technique of MR ventriculography, useful, but again, you need access preoperatively and postoperatively to an MRI scan. So the advent of using ultrasound to guide the endoscope was described, a number of times, but by Stravitsky in 2002, I find, most useful. 10 patients, but they really flushed out all the usefulness of ultrasound-guided endoscopy. And this is the kind of images intraoperatively that the ultrasound will give you for these complex multiloculated hydrocephalus. You can see placement of the catheter, final tip, multiplanar imaging showing exactly how these locules are orientated. This is the layout. Again, ergonomics are incredibly important. I'm not sure how many of these sorts of cases you guys see in your part of the world, but this multiloculated mixed density picture is quite common. And we use this sort of layout, ultrasound, endoscopy equipment. We've got a 6-handed technique. So myself, a registrar flushing, and one with the ultrasound. And our goal then is this sort of thing. This is what the intraoperative ultrasound scan looks like while we're fenestrating with the endoscope. You can see these are the microbubbles that we inject. That's what it looks like under the endoscope. We know that these two compartments have not been fenestrated, so we want to fix that. This is one again where we're in the cyst, but we know we haven't communicated it adequately with the outside. You can see the contrast medium stays in the cyst but doesn't leak outside. A sagittal view of the same thing. Injecting the contrast settles on the outside of the cyst, but nothing gets in. And then a case where we've adequately fenestrated. You can see we inject here and it goes all the way across to the other side. So we know we've adequately fenestrated that. So again, ultrasound for endoscopy guidance is really useful. Another incredibly important, condition occurring mostly in pediatrics where the ultrasound is useful is Chiari-1 deformity. So this is just showing, the bony decompression. Those are the options. But we always do a preoperative cine MRI. I don't know if I've shown that. Yes, a cine MRI to demonstrate, like absence of flow. And then intraoperatively, once we've done the bony decompression, you can see this is with the tonsils here pulsating. That's the dura still intact. You see good tonsillar pulsation, but again, it's difficult to interpret that. But so if you use the color Doppler, and I see flow around those tonsils, then I would accept this as a good quality control measure and consider not opening the dura, but doing just a bony decompression. So this is the case with a Chiari-1 and a syrinx. I wanted to show how the ultrasound demonstrates that syrinx. So we've opened the dura, we've shrunk the tonsils, but you can see the syrinx here. We then decompress that syrinx, and you can see once it's collapsed, the syrinx is completely resolved. A case now, I'm coming basically just to tumors. This is the case with a huge supratentorial, what turned out to be a grade 2 ependymoma. We removed it. Did quite a nice job, but that's all we could see under the microscope. And on the follow-up scan showed perhaps there's some residual there. We didn't see that on the microscope. And follow-up MRI scan showed residual tumor, maybe some recurrence, but really there was more residual. And the point being here, if we had a tool like intraoperative ultrasound, we would have picked this up and probably resected it, giving the chance to give the kid a better sort of progression-free survival. Again, showing the localization. This is a coronal tumor in the posterior fossa. You can see what that looks like here. On the ultrasound, very comparable. Intraventricular tumor on the MRI scan. You can see, again, these are very comparative images. It allows you to measure the cortex thickness, the depth of ventricular depth to the tumor, and the size of the tumor. Vascularity is something that's quite important for me anyway. So I'm able to identify the adjacent vessels. So the pica is here. That's the tumor. So I know that I want to remove tumor and tumor vessel, but preserve both my picas. So that's quite important. Depending on how much of this you do, we've got a research study now. I think it's mainly kind of in that context, research intensive, research useful, where we measure flow in those picas pre and post operatively just to see if there's any difference. Again, a picture showing the delineation of tumor. So MRI scan as it compares to the ultrasound. You can see in this choroid plexus tumor, both in the lateral and third ventricles, the ultrasound image compares very well to the MRI scan. In fact, the little stalk is better demonstrated on the ultrasound Doppler than it is on the MRI scan. This is an intraoperative demonstration of a posterior fossa tumor, what it looks like on the ultrasound, the MRI scan. During resection, we think maybe there's a little bit of tumor left. The image shows, consistent with that. Maybe there's more to resect, which we do resect all of that. You can see a nice clean flow of the fourth ventricle, the aqueduct there, and the image on the ultrasound is beautiful and clean. So it's nice to see that as a quality control, so you pretty much know what your post-op MRI scan will show. Okay, just some more examples. This is the case with an intraoperative residual. We knew we would left that behind because the patient became hemodynamically unstable. That was attached to the brainstem. You can see the ultrasound confirming exactly how much we left. So when we did the post-op MRI scan, there's no surprise. We know exactly how much we've left behind. For tumors in the spinal cord, this is the case that we resected. That's what it looked like. Before resection, we resected it completely, and you can see the cavity here with the kind of collapse of the cord there. This is a sort of quite a cystic lesion in the spinal cord here. This is during resection. That's after complete resection. You can see there's a nice clear cavity with good margin. So it's nice to confirm, no residuum. Limitations with ultrasound. This artifact at the bottom has always been a complaint of ultrasound users. But Gammon Ungsgaard has really driven a lot of the thinking in terms of ultrasound usage, especially for tumors. Is involved in a development company that is using an acoustic coupling gel that decreases this artifact significantly. Okay, in terms of ultrasound and post-op MRI scan, there's lots of evidence to suggest there's a good correlation between them. I'm just going to touch on some of the advances. 3D ultrasound, so combining 2D ultrasound with preoperative MRI scan has been advanced upon significantly over the years. Several companies, most notably now, the interaction between Brain Lab and BK Medical has been a driver of that. And this is all based on or mostly based on the work done by the same group in Trondheim, led by Dr. Ungsgaard. Contrast enhanced ultrasound, really a significant advancement. So that's what the images look like pre and post contrast. Injecting the contrast shows beautifully the vascularity. The quality of the image is impaired slightly, but the benefit of being able to demonstrate this vascularity is incredibly useful. And Francesco Prada has done huge amounts of work on describing the benefits of contrast enhanced ultrasound, and he always says the same principle of MRI scan. None of us would operate on a T1 MRI scan without contrast. And this benefit of the ultrasound and contrast enhancement is very similar to that. So lastly, strain measurement, whether one uses the elastic properties of tissue, whether these are kind of static based or shear wave, where you've got to sweep over the brain to kind of induce movement. This elastography definition between normal and abnormal tissue is quite useful. So I'm gonna end quickly with therapeutic ultrasound, high intensity focused ultrasound. There's been a huge drive in terms of the use of high intensity focused ultrasound. The principles I'm going to skip over, but effectively, that's the pharynx you're looking at, and you want to heat up the tissue. So the technique has been used by a number of companies, most notably, I think, probably Incytec. HIFU has been used in brain tumor lesioning, functional abnormalities to treat essential tremor, Parkinson's disease, and pain, and also disrupt the blood-brain barrier. There's been a lot of work done now. I think most of the early work was done in Tel Aviv and Brigham, but now all over the world, people are using ultrasound to lesion brain tumors. In terms of the functional implications, the initial work done, where the Focused Ultrasound Foundation is based really in Virginia, they showed significant improvement in patients with essential tremor, and we're still, I don't know if these results have been published yet, but they plan to target a different anatomical structure, treating not just essential tremor, but also Parkinson's disease. Disruption of the blood-brain barrier is also an important development. It allows increased delivery, or improved delivery rather, of chemotherapeutic agents into the brain by disrupting the blood-brain barrier. Okay, so I'll summarize. I mean, that's a big overview. I've gone through it fairly quickly, just the time constraints and the sort of technical issues that Dr. Leonardo had. But I think, if you look at this quote, it perhaps summarizes it best, that some things take a little bit of time to learn and the effort is quite troublesome, but the broad or the larger implication and benefit in terms of how it's applied to our use is really worth all of that effort. Okay, so I think the fact that all of you would attend this or through the NeuroSound Academy means you're familiar with the fact that ultrasound is safe and cost effective. Its indications rather range from diagnostic to navigation as a surgical adjunct, also therapeutic and neuromodulation implications. So I think it's got incredible potential, not in the next few years, but already. And it's certainly worth making the effort to integrate this into our normal theater, not just theater, but also our diagnostics and neurocritical care, and as a screening tool workflow. All right, so I've tried to shorten that quite a bit, and I probably rushed through it a little bit, but it's quite important to try and make up for time. So Leonardo, I wait to hear any questions from yourself or any of your colleagues.
Okay, thank you for your words. It's wonderful to see all these 360 possibilities of ultrasounding neurosurgery. I'm passionate for ultrasound nowadays, and I use it in my clinics. I use it in the OR and the emergency room, in the intensive care unit. So to me, it's very interesting to see how people abroad still use it, also use it for these many purposes. I have one of the works I sent to the Congress in South Africa in December is about optic nerve sheet diameter usage in clinics. So I have two cases in which I changed my decision to operate or not to operate based on optic nerve sheet diameter measurement in the clinics. So there was one I was considering to shunt, and the other one I was not considering to shunt, but then I did the optic nerve sheet measurement, and I identified papilledema and increase in the diameter. So it changed my mind in a way to operate or not. Also, I have used it for central retina artery Doppler. One ophthalmologist sent a patient to me considering occlusion of the central artery, and I could identify it was not occluded just using Doppler in clinics. I didn't need to use arteriography and contrast enhanced exams. So the patient had a solution for his this hypothesis, and we could give it an answer very quickly and safe way. I really appreciate all your slides, and I would like to ask you about the acoustic coupling gel. You mentioned you use generally the same that they have approved for UNSGARD in Northern Europe, or do you generally use microbubbles?
Yeah, so I look. I mean the acoustic coupling fluid that Dr. Ungsgar is developing is still in its research phase, so it hasn't been commercialized yet. But as I understand it, that's going to happen fairly soon. But I mean, we kind of run a lot of these workshops together, and I've seen the quality that the imaging, improves, or the quality of improvement in imaging. And I think that's certainly something to look out for. I think it's going to change a lot of, how widely ultrasound is implemented. So I use saline depending on what I'm imaging. I use sterile ultrasound gels, and it works incredibly well. But I think a decent coupling fluid, and you'll see if you've ever listened to one of these talks, that it is modified specifically to brain sonographic properties. So it really improves the quality of imaging and reduces the artifact. So I think when it comes out, it'll be a game changer. But at the moment, the quality of imaging is pretty useful just with normal saline.
Thank you. Just one more question, and I'll open to everyone. And elastography for hydrocephalus, do you have any experience using it for deciding if the ventricles are very stiff or not?
Yeah, I mean, that's an excellent idea. I haven't used it for that, but I'll have to look. Is there any data? I'm not sure if there's any data on that. It sounds like an interesting concept. I've never used it for that, but sounds like it could be quite an interesting area to look into.
Yeah, I was reading a paper recently, and it was very interesting to see this possibility to use elastography in hydrocephalus, and also they use a lot in epilepsy. I'm not sure if you use it in that purpose also, for identifying this plastic area to remove.
In that context, yes, I think it's pretty useful for that. Hydrocephalus, no, I haven't done that.
Okay, thank you. Does anyone has a question for Dr. Padayachy? Oh, Andres, you can open your mic, Andre.
Oh, hi. Uh, Hello, I'm talking from inside the OR, so sorry. It was very interesting to see the video processing of the nerve sheath diameter. And my question is it available, Dr. Llewellyn, or is it something you're working on? Because it is the most, let's see, the most, the impediment, the limits of using the nerve sheath diameter are related to its compliancy, to its capability of containing the fluid, the cerebrospinal fluid. So I am very curious about this work and if it's already available or not.
Thanks, Andre. Yeah, so we've put a tremendous amount of work into exactly, what you're saying. It's not a standalone, because the optic nerve sheath diameter is a static sort of point in time, and its ability to distend, like you quite correctly say, depends on the elasticity or compliance of the sheath, and that's what this work has been kind of focused on. So it is available through a company called Nisonic. The CEO of the company, Thomas Selbach, is at the moment, what we're doing is refining the machine learning algorithm. So we're just improving diagnostic accuracy, and the software certainly is available. But what we're trying to do at the moment is implement it in various conditions. So there are several collaborative efforts going on with research centers in the States, in Europe, Africa as well, to try and refine this. So it should be commercially available, if that's what you're asking, probably within the next couple year or couple of years. But the process of refining it is ongoing, and that is something that we're doing with a number of centers now.
Thank you.
Thank you. Ricardo, do you have any questions or remarks?
Yeah. Hi, everyone. Can you hear me?
Yes.
Oh, great. Good to see you again, Padayachy. It's good to see your experience again. So I have one question for the young people that are beginning to use the ultrasound. Do you have any tip to turn the learning curve more fast? Because, as you know, sometimes the learning curve is not so fast for some guys. Because ultrasound needs a bit of experience to interpret, to know exactly what it's seeing. Do you have any tip to increase the learning curve to ultrasound?
So I'll just make a quick comment on that. Thanks, Ricardo. Good to see you. It's been a while since we chatted the last time. But I agree with you. I think it implements itself fundamentally in the workflow if you're comfortable with it. And that is very much learning curve dependent. And, those initial kind of usages where you're not quite sure what you're looking at and you're not quite sure how to drape or sterilize the probe. Those sorts of things we encourage, like you've done, and like you've encouraged your your guys through the Brazilian Pediatric Neurosurgery Society to do, is to attend the courses, to learn the very basics. And once you've done that, using it for cases that maybe you could do, even without ultrasound, or where the indication for ultrasound is quite soft, using it so you get used to the applicability in those cases. For me, whenever you can use the ultrasound, use it, is something we always say. And that just, drops the steepness or flattens that curve significantly. You become familiar with it, even more than you would have anticipated. So we've really encouraged people to get it into their routine workflow. The more you use it, the more comfortable you become with it. I think the more comfortable you become with it, the more you enjoy using it. And the more you enjoy using it, the more you'll use it, the more proficient you'll become, I think. So it's very much that sort of self-fulfilling prophecy. Just, do the basics, attend the courses, and then just use it, as often as you can.
Thank you.
Fantastic. Dr. Padayachy, do you use any cover over the keyboard of the ultrasound, or do you ask someone who is out of the surgical field to make some adjustments during the procedure?
So I'm going to answer that very much in my personal context. When I started out doing this as a registrar and as a young consultant, it was very much me doing it. So I had to sterilize the entire, the keyboard and the probe, because I was doing everything myself. Fortunately, as I've gotten older and more people have started joining, I've got research fellows, PhD students, and master's students, stacks of them. So they're always in theater with me. So I sterilize the probe, but I don't have to sterilize the machine itself, because there's always 2 or 3 students around, involved in some sort of research project that do that for me now. So I think as you grow with that, you'll see this yourself. It's an incredibly attractive tool, to show people what the tumor actually looks like on ultrasound, is not that difficult to generate interest. And, I think as you start using it more and more, you'll find more and more people want to come and get involved in it. So yes, when you're starting out, I think you have to sterilize, at least drape or put some sort of sterile plastic cover over the keyboard, because you'll end up doing a lot of it yourself. But hopefully if it grows into some sort of entity, then you can, you'll have guys to do it for you.
Yeah, this is kind of one of the troubles I have nowadays, is to inform during the procedure how someone who is close to the keyboard, which buttons he or she needs to press and to rotate, and sometimes it takes a little to the person to understand what you're trying to say. But I'm improving, and I think nowadays I have better results in communicating with these people than I had 3 years ago when I started intraoperative ultrasound. So it's becoming more natural in many ORs that I work here. Okay. Well, does anyone else has questions? Okay. Well, Dr. Padayachy, well, thank you. I would my last action today will be to ask you if you please could pick 3 numbers from 1 to 4 in order, just that I'm doing a contest here, and I will give some registrations of the course for the remaining audience of the webinar.
Okay, I hope I understood you correctly. So I'll pick 1, 3, and 4. Is that
1,
right?
3, and 4. Okay, perfect. And then using the alphabetic order of the remainings here, we'll have Carlos, Gustavo, and the other one left. Well, okay, João. Okay, they are the winners of the Lionel is back. Okay, so it's Carlos, Gustavo, and Lionel in order. 80%, 60%, and 40% discount on the course. Thank you. I'm very happy to start this NeuroSound webinar with your presentation, and I hope to see you soon in South Africa to see more closely how you work and how you have this amazing results and publications. Thank you. This is
Thank you so much.
my last words.
Best wishes to you.
Thank you. Bye-bye.